Next up on the classes of oral medications, we have the SGLT2 inhibitors. This includes canagliflozin, which is Invokana, dapagliflozin, which is Farxiga, and empagliflozin, which is Jardiance. These work on the sodium glucose transporter 2 receptors in the proximal tubules of the nephron, basically to prevent reabsorption of glucose in the kidneys. Because of this effect, they can cause, of course, genitourinary infections. All three of these classes on this specific slide have similar A1C efficacy of 0.5 to 1% in ability to lower the A1C. The next class is the bile acids quotient, which would be colesevelam, which is also known as Welchol. The mechanism of this drug is it binds to bile acids in the intestinal tract, which increases hepatic bile acid production. Now, this specific mechanism probably mostly applies to hyperlipidemia, which this drug is also indicated for. The mechanism of action specifically in diabetes is actually unknown. Some clinical pearls, though, if the patient does have that hyperlipidemia, that can help lower that LDL, but because it's a binder, it can decrease absorption of other meds in the GI tract. And then the last class of medications that's very not really used is the dopamine 2 agonist bromocriptine, brand name Cyclocet. This one also, just like the class says, it's a dopamine receptor agonist, but specifically this mechanism is really unknown in diabetes. It's thought that the dopamine is believed to be associated with the circadian rhythm in the body, which affects obesity and insulin resistance. A1C efficacy of 0.5 to 1%, and a clinical pearl is the side effect of it could be dizziness and syncope. So now that we've gone through all the medications, we kind of just wanted to go through what the guidelines say in terms of what kinds of medications to choose, when, etc. So first up, we have the AACE/ACE 2016 profile of medications. This slide is really helpful because it helps compare all the main side effects that you may experience with the different classes of diabetic drugs. So of course we're concerned with which drugs cause hypoglycemia, which would be the sulfonylureas and the insulin, weight gain or weight loss, how it affects renal function or if it's contraindicated in renal function, GI upset, cardiac effects, and also bone effects. This next slide is the ADA 2016 guidelines therapy chart, and basically we always want to start first line with monotherapy with metformin, and as you move from monotherapy to dual therapy to triple therapy, you always want to wait at least 3 months in between adding on that next medication. If at that 3-month mark there is no, or the patient hasn't reached goal of A1C, that's when you consider adding on an additional therapy. So metformin is always first, and then from there you always want to add on a different drug class. And this chart does have some helpful tips of efficacy, hypoglycemia risk, weight, side effects, cost, etc. And then this last algorithm is also very helpful. It's the AACE/ACE 2016 guidelines algorithm. This one is very helpful because this helps gives us a hierarchy of drugs to use. So as you can see, like if you're looking at the dual therapy section, after you've of course had metformin first line, it kind of gives you that recommendation of the GLP-1 receptor agonist would be an awesome addition for this an awesome addition for the dual therapy above the SGLT2, which would be above the DPP4s, etc. So back to patient DM, how does this apply to our patient? So why did we choose to go with the triple therapy with our patient and add that Invokana? So the patient had been trending down in A1C from the previous visit, which was 3 months ago, from 8.5 to 8.3. If they were trending up, we might consider something else, like telling them they really do need to add insulin. But of course, the patient is not interested in it at this time. And since they are technically still trending down, that's why we decided to choose it. Also, it's appropriate to add on additional therapy because it's been 3 months since we've had any changes in therapy. And as you can see from the previous slide, besides the GLP-1 receptor agonist, which is an injectable medication, the SGLT2 and the DPP4 inhibitors, which the DPP4 inhibitor that the patient is the Jardiance, and then the SGLT2 is the Invokana that we want to add. Those are both high on the list for the suggested hierarchy for this patient. Here are our references. Thank you for listening. Please let us know if you have any other additional questions. Have a good day.